forward to this computer. All right. All right, cool. So thanks to everybody for being here tonight. This is the maiden voyage of the Trauma Nursing Journal Club. And really the purpose of the Journal Club is just really to have a good time. Really wanted to bring together individuals, like-minded individuals who love trauma nursing, and kind of throw topics of interest our way. Give us a chance to discuss them, give us a chance to debate them when appropriate, and really just have a good time at the end of the day. And that's what you'll see kind of my incepted goals of this, really the rules of Journal Club, if you will, really just are, a review of the current literature and how it impacts our practice as trauma clinicians, evolve a little bit more of advanced trauma nursing practice model at our institution. And also, okay, hang on, did I just lose my screen? There we go. And you guys still see my screen, Shiloh? Thumbs up?
Yes, okay. Yes.
Obviously this becomes an idea for maybe possible research that can be done within the institution or papers for publication. And then obviously we want to foster professional socialization amongst us as clinicians. So hopefully that will happen. And we'll go from there. Shiloh, is my screen flickering in and out at your end?
It's not on my end.
Okay, good. It's probably my end then. Okay. And of course, we want to have fun at the end of the day. That's the cool thing about this. So, one of the things that I'm hoping to do going forward is we'll have an ad mix of not only research articles, because research articles, even though they're cool, they're boring. And trying to interpret them or understand the statistics is scary. And tonight is absolutely going to be no adversity to that. I tried to pick an article that was pretty low key on the research in the statistical side, only to find that in any research paper, there's tons of statistics that I think are almost, expected that have to go into them in order to get accepted for publication. At the end of the day, it all comes down to the p-value, and we'll talk about that. We'll see that in tonight's paper in particular. But moving forward, the ad mix will be not only that of research articles, but also my goal is to be able to have some clinical articles, and those clinical articles will serve as a fodder for perhaps somebody coming up with some concepts and some ideas. And this will also dovetail into another initiative that we're working on, and that's going to be on a quarterly basis doing what's called Topics in Trauma Care. And Topics in Trauma Care will really be a kind of a lecture or a talk on a topic of interest in trauma care. And my goal for that really will be that whoever I can cajole, bribe, and or give lots of alcohol to in order to create maybe a presentation, that they can turn around and write that presentation up for publication, and we'll get you published. I do have a few inroads with some of the journals, Journal of Emergency Nursing, with regards to getting some topics published. So we'll work on that. But without further ado, I want to spend probably about 30 or so minutes of our time going over the article of interest tonight, allowing plenty of time for any commentary either along the way or at the end, depending on how you would like to play this. This is really owned by you as the participants. I'm just kind of here to kind of guide us through some stuff. But at any point in the game, if you if you want to speak up or you want to say something, please feel free to do so. I don't want this to be the Steve show. This is the show for all of us that are here. And right now, with the exception of Shiloh, thank you, Shiloh, for showing your lovely face, are incognito, and that's okay. I don't have a problem with that either. So tonight's article and just want to check this before we go on, audio and video right now, everybody's good with that? All right, cool beans. So tonight's paper that I chose is a article out of the Journal of Trauma Nursing. I am a Journal of Emergency Nursing fan, a little biased to it, but the Journal of Trauma Nursing is obviously an excellent journal, and it is a journal that focuses on trauma care. So I felt it was really appropriate to pick the kind of the first article for our journal club out of that journal. And I found an article that I thought was kind of interesting. Trauma bay time clocks, influence on emergency department length of stay. What they say when it comes to developing research and publishing research and developing a research study, your title should tell you everything you need to know about the research topic, but without being like a paragraph long. So I think that the authors did a pretty decent job here of giving us a relatively short title and, taking a look, if you will, on what their end goal really was. And we'll talk about it a little bit more, and we can even critique it a little bit as we move on. So by way of introduction, the authors initially go through a pretty lengthy but pretty succinct introduction on the review, as a review of trauma resuscitation in general. They cite the way typically a trauma resuscitation is done. Trauma team activations are contemplated. In particular, you can tell in reading the introduction that these authors are in Southern Texas because they're part of the STRAC system. STRAC system is a phenomenal trauma system that's in place in Texas. They've actually taken the state and divided it up into different segments and created a trauma system down there that is really very, very cutting edge. But they also, like all of us, follow the American College of Surgeons Committee on Trauma Orange Book, soon to be the Gray Book any day now, which really is the Bible, if you will, of trauma care. And in that, they appropriately summarize, when you're working in a trauma system like ours or a trauma center, you have levels of trauma activation. So in particular here, that they kind of go over that. They go over a little bit about what it means, about how the system is set up and how it works, which I think is important for both the trauma clinician as well as the non-trauma clinician reading the article. They go over some quality indicators, which I think were kind of interesting. And the quality indicators really did center around overcrowding, hazards of overcrowding, particularly on the trauma patient. But the fact that obviously quickly caring for any patient that comes through the door of an emergency department is important, but none more so obviously than the trauma patient. Certainly any of us that have been in emergency nursing even for 5 minutes know the plights of ED overcrowding. I've been in emergency nursing for 35 years, and I can remember my very first night on the job as a new grad in the ER was an overcrowding situation, and it has not left us 1 minute in 35 years. So ED overcrowding is problematic, and it does impact care provided to patients, be they trauma patients or non-trauma patients. And this article doesn't talk about it, but it has a major psychosocial impact, if you will, on those of us that are the providers of care in the emergency department. Hey, Lewis, thanks for joining us.
Okay, chill out a little bit.
So, that being said, when we look at this, and particularly the authors of this paper looked at stuff, they really looked at this and they made it as a performance improvement project. One of the things that they noticed within their trauma registry was that the length of stay of some of their trauma patients had increased over a 2-year period compared to the data from 2 years previously. And that's part of what we do in a trauma program. Is we look at our data, and we look at our data in a manner in which we improve the care we are providing. At St. Joe's or any trauma center that you work at in the state of New Jersey or really across the country, there are all kinds of benchmarks that are in place, and we're always competing against these benchmarks to better ourselves and to be the best that we can. And one of the particular items of interest at this particular trauma center was the fact that they found that the length of stay of the trauma patients, particularly those that were either needing to go to the operating room or needing to go to the ICU, seemed to be lengthening, and that was a bit of a problem. So they sought a way to try to reduce this length of stay in the emergency department. And again, it's not rocket science. You don't have to be picking phenomenally big, complex topics when it comes to looking at these projects. It's the simple ones that can make the biggest difference. So what they basically did is, based on their quality findings, is they decided that they would put a giant clock, if you will, stopwatch, at the head of their trauma bay. And I am actually trying to buy this clock. It is sold out in every place on the internet that I have gone to find it. But I promise you that as soon as I find out where I'm going to buy this clock, I'm going to buy several of them. But at the end of the day, they really kind of hypothesized that, if we put a clock up there and we're staring at this giant clock ticking away, is that going to be a reminder that we need to move our asses and get patients out of the emergency department quicker, trauma patients? So, they did this, they identified it, and kind of the now what was, let's see what we can do. What can we do to make things better? So that's really kind of what it came down to. The study objective was pretty straightforward. It was to measure the impact of using trauma bay clocks on emergency department length of stay of these trauma patients. The thing that gets a little mired down here, and you can get a little minutia up, is emergency department length of stay in general. We always think about, all patients, all comers, everyone coming into an ED. What is their length of stay? The ED length of stay in this study and in tangential to the study was those trauma patients, or those patients specifically that were coming in at one of their two tiers of trauma team activations, which would be the equivalency of our trauma code as the highest level of trauma activation, or just the trauma activation as our middle ground. They describe study methods and designs that are pretty straightforward. They are a trauma center that sees about 3,000 trauma team activations per year. So their trauma registry is pretty healthy. That's a good number of trauma patients. They're a level 1 trauma center in Texas. And everything's bigger in Texas, as we know. The time span of the study was a 4-year period. So this was a period that it required some investment in time and effort. But they wanted to try to get as much data as they could in order to have a data set that would really allow them to be able to ultimately, at the end of the day, show that their quality initiative was working. Their inclusion criteria was pretty simple. It was all of their trauma team activations that were admitted to the hospital during the study period. They had a 2-year period where they had collected data previously prior to implementing the time clock study, and then they were going to collect data for 2 years after the implementation of the study. Inclusion criteria were pretty straightforward. And if you really weren't a trauma team activation, either in their scenario, either a full trauma or a partial trauma activation, or in our case would be a trauma code or just a standard trauma activation, then you really were excluded. If you were downgraded, if you died, obviously you were only going to go to one place, and it wasn't going to be the OR or radiology or the ICU. If they left AMA, that never happens. That trauma patient who comes in and we're all gussied up and got our gowns on, only to find the patient wants to get up and walk out 30 seconds after they get there, that never happens. And then those that are actually discharged from the ED, which, surprisingly enough, is a pretty significant number, because the science of pre-hospital trauma triage is certainly not exact. And they developed comparison groups. They had their first group, which was really the QI population that they initially established when they looked at the initial trauma subset in their registry, and then their group 2 were those that were collected in a 2-year period after that, after the implementation of these clocks. One of the things that I wish they would have done, and they didn't, while I'm thinking about it, is I wish they would have put a picture in the article showing the clocks and what they looked like and where they were positioned. They didn't do that, and I think that would have been somewhat helpful. I made a note to myself to actually reach out to the authors just for my own edification and ask them to just send a picture of it. I think that would have been nice to see. It was an IRB approved project. For any of us that know even a little bit about doing research in our institutions, is everything goes through the institutional review board just to make sure that we are conducting research that is ethical and germane and spirited in the right level of development. And then they went on to do data collection through their institution's trauma registry. That is the purpose of the registry, is to collect all of this data, and for you to be able to take a look at this data and pull all kinds of numbers and statistics and really do some cool stuff. And I'm going to take a minute now just to kind of introduce Shiloh Lunsford. She doesn't like the attention, but I'm absolutely going to give it to her because I got her in front of the camera here. But Shiloh is a member of our team in trauma services. She is the project manager who oversees all of the trauma registers that enter trauma registry data for St. Joe's. And if I'm not mistaken, Shiloh, we've got 4 registrars in one shape or form that are entering data from just our center at any given time. So it goes to show you the labor intense nature of which data is pulled and gleaned and abstracted. So and again, perfect place to get it. And really the purpose of having the registry, or one of the purposes of the registry, is to be able to pull this data, collect it, have good solid data to be able to then do some quality assurance projects or even good research projects. They collected data that was pretty straightforward. They looked at the age of the patient, the gender of the patient. They looked at the injury severity score. And for those of you that don't know what an injury severity score is, I'm not going to get a tremendous amount into it now, but really it is, in totality at the end of kind of the patient's discharge, really seeing how badly the patient was injured. And as a kind of as a matter of principle, somebody who's got an ISS greater than 15 is typically considered to be a moderately injured patient. And then I think the ISS, correct me if I'm wrong, Shelley, I think it was a 25. Is that right? Okay. So yeah,
25 is severe.
yeah,
Yeah.
25 is severe. Yeah. And what's the highest number you can get?
75, but
Yeah,
usually
so
that's for non.
yeah, you're not going to survive that one. So if 15 is like moderately severe, when you're getting up to 75, it's hope your life insurance is up to date. So again, they were looking at the injury severity score because they wanted to compare. I mean, how badly were patients injured? And obviously, you would think, and again, it just goes without saying that the more injured a patient is, the quicker they're going to come and go out of your trauma room. Somebody who comes in with an ISS of 50 or an ISS of 70 who's still alive is not going to spend a heck of a lot of time in trauma rooms. And in fact, there are trauma centers around the country now that they don't even go through they go through the emergency department as a pathway to the operating room. Do not pass go, do not collect $100. It's go right to the operating room. And then they've got these incarnations of what are called hybrid suites or hybrid trauma resuscitation bays, which really have the ability to do trauma resuscitation, interventional radiology, and operations all in one room. So you really just go into one room, one size fits all, and boom, once you're in that room, you can do anything you want, which is kind of cool, expensive, but pretty cool. So anyway, I digress. So back to the fact that they were looking, obviously at how badly these patients were injured as a comparator. They also were looking at a number of different variables, such as, how long were they in the emergency department, how long it took to get to radiology, to get to OR, and ultimately to get transferred to ICU. They really didn't talk about those patients not going to ICU. I think it's more implied that they really wanted to get the sicker of the patients out quickly. So they really kind of, the reference is more toward the ICU admit more than it is anything else for the purposes of the data that they seem to present here, at least as I see it. And then their emergency department length of stay, at least was it's defined in the study, was the time of admission until the time of arrival in the inpatient unit, or in the case of those going to the operating room, those going to the operating room and leaving the domicile of the emergency department. Doing okay? Anybody have any questions thus far? All right, cool beans. All right, so I'm going to breeze through this just as quickly as humanly possible. If you look at this, there are a number of statistical elements that they did. And I love research and I love trying to read research, but I'm going to tell you, this scares the living crap out of me, as I think it does almost anybody. I've had the pleasure of being able to, go out and have drinks with people who can look at this stuff and read this stuff like it was 1 + 1 = 2. And the more alcohol I get into them, the more they're able to actually keep explaining it. So there's some part of the brain that my head hasn't kind of wrapped around yet that just allows them just the ability to be able to do wonderful things with numbers. And I've never been there. But anyway, these are a number of the statistical analysis that they did. Look, for the purposes of what we're looking at here and whether or not this thing works and whether or not there was some positive outcome to it, it all comes down to the p-value. Okay, the p-value is the end all be all in most of the research that you're seeing out there in emergency and trauma care. And the p-value, if you're not really associated with it, basically says, it's the probability that what is happening is just happening by happenstance. It's just a stroke of luck that it's happening that way. The p-value is almost always assigned to research studies of being less than 0.05 or less than 5% chance that it is actually happening just through happenstance. Anything less than that is considered to be quote unquote statistically significant. The lower you get from 0.05, the more statistical significance there is, which means the more likely is that what you're seeing maybe actually is true and is actually something that you can hang your hat on. So I'm just going to kind of leave it at that. That is the Steve Wyman version of Statistics 101. Thank you very much. You'll see me on YouTube in a 15-second video next week. So let's look at some of the results that are here. The results are interesting, and the results are also a little bit quagmired. This isn't one of those tables, unfortunately, that you can look at and really glean good data from very quickly. You have to read it and digest it and go back and forth. At least I did, between what their results were and then what they listed in the table. At the end of the day, when they looked at stuff and they looked at things pre-implementation versus post-implementation, there wasn't a tremendous amount of statistical significance there. And that's okay. I think that's where you don't want to see a lot of statistical significance, is you want to basically see the populations really are paired up pretty decently. The only statistical anomalies they had, gotta go back up. I thought I checked the box there. The only big statistical anomaly they noted, or statistical significant thing here, was the gender of the patient. In the pre group, about 76% were male, and the post group about 71% were male. Again, it doesn't look like that's really a tremendously large number, but in healthcare and in healthcare statistics, even a small percentage of it like that can be deemed to be statistically significant. The other thing that was on here that was a little statistically significant was age of the patient. And again, you don't think of 2 years difference in age being significant, but at least the math here is pointing to it. They really didn't give any rationale as to what the implications were of that statistical significance. I don't personally believe that it's overly relevant for the purposes of what they were looking to study here. Then we look at the results from the standpoint of and they reported the outcomes separately for those that were full activations in their system, which is the equivalent of our trauma code, and then those that were limited activation patients were essentially our basic trauma team activation. And there were some significance here, and the significance here really bore out their hypothesis, if you will. And their hypothesis was, number one, is that putting clocks in there will help throughput. And if you look at their data, they certainly show that. Here we go. So you look at the data at the top, in particularly 2 sectors, the amount of total time they spent in the emergency department, it was statistically significant. And then it went from 39.2% that they were able to get out of the department at 50 minutes or less prior to the clocks to almost 62% afterwards. So not quite a doubling, but I mean, even that just number, you don't have to have p-values there to show that that's pretty significant. And again, the p-value showing it almost as low as you can possibly be. You usually don't see a less than on your p-value unless the p-value is like relatively very low. So that shows some pretty decent statistical significance in the implementation of this time clock. So it's almost checkbox 1. They did a good job. Their hypothesis has somewhat been proven that indeed the clock does seem to get patients out a little bit quicker. The other thing was obviously the duration before they went to the intensive care unit. It wasn't as significant on numbers, but the p-value is almost equally significant. And in that case, it went from about 45.3% that we're getting out of the ER in just a little under an hour to 55%. So, almost a 10% difference. And once again, 10% is statistically significant. And when you particularly look at the number set that they were looking at here, this was over I think it was close to 4,000 patients in their set. When you're looking at those numbers, I got to tell you, this set had 1,200 patients in it. So you're talking about 120 patients that they were able to clear quicker out of the emergency department as a result of using it, which, is pretty cool. The other thing was in the limited activations, likewise, very similar results there. They showed statistical significance in getting even their less critical trauma patients out in less than 50 minutes, and also getting them to the ICU in under the 56-minute benchmark. But what I thought was also very interesting in this, and they really didn't talk about it, was the duration it took them to get to the operating room. They're actually in the pre-sec, it was kind of interesting that the numbers actually went down. In fact, they were getting patients to the operating room quicker before the clock than after the clock. They really didn't explain what that was, and maybe that was an aberration, I don't know. But in the partial group, the ones that did go to the operating room, which was a smaller group as you would expect, they were less injured. was pretty significant. It went up almost 20%, but they didn't find statistical significance in that. So that's kind of the funniness, if you will, in looking at something that's statistically significant and what it's not. And in this particular group, the statistical significance not being really there might be because these were not really seriously injured patients. These might have been patients that went to the operating room for relatively stable traumatic injuries, maybe open fractures, maybe things like that, that, we didn't need to necessarily get them out of the operating room quick because they were going to die. We just got them out of the operating room because, it was there and didn't reach, if you will, the power of it being clinically significant, if you will.
Can I
Absolutely,
something?
Sam. Please do. Please.
So, like, when I was reading that and thinking about that information, it's like anything that can help is good to research and to try. And I just kept like pondering, like, is the clock doing something, right? Because you can never determine what that sample size will be reflective of in your trauma population. And also, like you said, like the more simple surgical cases, right, they have time. Like, it's not urgent, right? Like the case dictates the pace for the most part. And like being that after the clock, the surgical cases seem to take longer to get to surgery. It almost seems like it's statistically irrelevant because it's hard to research a trauma setting because it's so, the samples, the population that we're sampling from, that we're examining, is so unpredictable, right?
Oh, yeah. Spot on. And you're right. That's what makes research very difficult to do in emergency and trauma care in general. And for the variety of studies that we try to do. But that's a really good pickup point that you hit there. And there's also variables, obviously. I mean, having a clock, particularly for patients going to the operating room, having a clock is great. We could be ready to send our patient to the operating room 2 seconds after they get there. But if there's no OR availability, or we're calling in a second crew because the OR is busy, that's not a lack of us being able to get the patient through quickly. It's just the system isn't allowing it to happen. So, and again, I think a lot of that might also play into looking at some of the significance here as well. So yeah, sure, absolutely.
My question is, for this clock, is this clock like a clock where it's like just like the normal 12-hour clock, or is it a clock saying, okay, we've been with this minute for 1 minute already, and it's just building up the time as we're with the patient? So like, we've been with this trauma patient for 30 minutes already. So like, how does the clock look like?
It's a stopwatch. It's essentially a giant stopwatch. When the patient comes in, you press a button and it starts. Is kind of what I remember from the article.
Yes, that's what they allude to. But like I mentioned earlier, it would have been so nice if they would have put a photograph in there of that clock. I mean, I think it's great and everything. They had their tables and all that beautiful stuff, but give me an extra, 1.5 inches of column space to put, a black and white picture of what it actually looked like in there. But yeah, I agree with what Sam said, Kimberly. I think it's probably nothing more than a giant clock that it starts off possibly at time 0. And then it just counting, minutes as it goes by as a reminder of, hey guys, you're now at 10 minutes, 15 minutes, 20 minutes. Does that make sense?
Yeah. The thing I was also thinking about is when it comes to like research, obviously you don't want to test too many variables, but it's not really an optimal clock design. I feel like in the resus room, whether it's CPR bay or in the trauma bays, having the clock that is tied to our computer system, so it's a standardized time, right? Instead of, we always have someone puts their phone out, everyone looks at their watches and stuff, but this is the time. This is like the Bible. This is our Bible time, that clock.
Yep.
Period. And along with that time, when the alert comes in, you start the timer. So and you could research that further, saying you can measure outcomes based upon length of time from it being called to getting our hands on the patient. Then you could look at the second timing of when that patient's actually in our care, versus, the different destinations we're trying to get them to.
Yeah, no, I agree. Absolutely. Shiloh?
Earlier I was associated with the level 1 trauma center, and their clocks were 2 squares. The one on the left was an actual digital clock with the actual time, which what he was saying it's your ground zero time. So regardless of what EMS run sheets say, if the time stamps are different there, the clock in the trauma bay is like you was saying, ground zero. And then in the square right beside of that was the ticker clock. So that way you had the digital clock to record all of the timestamps that are needed for everything in the trauma bay. And then you constantly on the other side have got this counter, like he was saying, but typically those are the ones that I've seen historically that I've actually witnessed.
Yeah, no, you're spot on with that, Shallow. When I was working in Kansas City in our trauma center, we had sitting behind the scribe on the wall was a giant face clock that was the Bible time. That was your reference time. That was the time you went by. If your watch said 6 o'clock and that clock said 7 o'clock, you were going by 7 o'clock. And then there was a digital readout below it, a separate clock, so it caught your attention as being different. That if the scribe nurse remembered to hit the button, then that was your countdown of how long the trauma was going on for. So, and again, I don't know. I mean, we can only conceptualize based on what we're reading in this article as to what they had. Like I said, I'm going to reach out to the authors and just for S&Gs get them to send a picture of what it was, because now that we're talking about it, I'm even more interested in knowing what this damn clock looks like. So anyway, that being said, so you know, at the end of the day, the discussion component of this kind of article did go on to talk a lot about ED overcrowding and potential solutions. There were some reference articles that were popped back and forth. One just quick editorial comment there. A lot of their references and stuff were relatively old literature. You know, the publishing mantra really is that, you know, your literature should be cited within about 3 years of publication. Anything older than that really needs to not be utilized unless it's something fairly landmark or significant. And sometimes with research, it's a little bit different, but they did cite some articles that were going back 15, 20 years on ED overcrowding that I know that there have been recent articles that have been written and hypothesized on that are a little bit better, but I don't want to digress because those were generalized ED overcrowding articles. They talk a little bit about some different way that centers were doing throughput and pre and post time clock implementations. They were talking about some stuff there. They talked about, you know, obviously there was improved throughput in the overall length of stay time and ICU admission and whatnot, which was good. Those, you know, those two variables are important to know. And certainly they did prove that, you know, at least the implementation of the clocks during that study period seemed to be affording them some positive outcome. The cost was certainly nominal. It was a $400 clock. So, which leads me to believe this is kind of an interesting clock, probably not just a standard. You know, I went to Ace Hardware and bought like one of those, you know, clocks that the 9-volt battery or AA battery goes in the back of, but again, I don't know. So we'll try to find that out. And if I do find it out, just because I'm a sharer by nature, I'll send everybody a copy of the clock so you can have it. And, you know, they didn't really find any significant differences in time to radiology or time to the OR. But again, those are sometimes variables that are less problematic than sometimes admit to the floor. But even admit to the floor, as we know, that's sometimes a variable that we can be ready to transfer a patient to, you know, the ICU yesterday, and we're waiting for a bed, or we're waiting for the nurse to come back from the break, or we're waiting for housekeeping to come up and clean the wall of a patient that's never going to touch a wall or something like that. And then they talked about a variety of different studies where they looked at different timing mechanisms and countdown timers and interval timers and situational awareness timers and all of these things. And they kind of proud themselves that they're the first center to actually report on the use of these time clocks prominently placed within the field of view of the clinician. Even though we know they're out there, they're absolutely right. I did a real quick look at Doc Google, and I didn't really come up with anything that showed that this had been done before. So this really was kind of a novel, if you will, solution based on a lack of the literature and a process improvement component for their quality assurance program. Limitations. Every study has its limitations. It's up to the authors to try to identify those limitations. And I think the author did do a pretty decent job of looking at it. You know, it was a retrospective design, although it wasn't entirely retrospective. I mean, they were prospectively gathering data for their second cohort of patients. So it wasn't really a true retrospective design of that nature, but that's really neither here nor there. They mentioned something about user variability and initiating the time clock, and that kind of raised a red flag with me when I read that. I'm like, what does that mean? Does that mean every once in a while I was 5 minutes late and hitting the button, but I still included the data? You know, I don't know. Again, they don't really, at least that I saw, explain that in any detail. They talk a little bit about data collection and reporting accuracy. You know, again, you know, think about how we're doing this. This is, and I don't know what their trauma documentation system is in their trauma bank. I don't know if they are using real-time Cerner data entry, which some trauma centers use but hate generally, or they're using like we do, which is a paper form that then gets either abstracted later or uploaded into the system, more kind of like what we do. But you can only imagine that there could be some reporting inaccuracies between what is reported or what is documented by the scribe nurse, and then ultimately what then gets copied and sent to the registry personnel, and then what they put into the computer. So those certainly could be, I think, some logical limitations when looking at a data set of this size, where you're relying largely on registry data. And then I came up with a couple of myself, and I'd be interested in if anybody else came up with some as well. There's the Hawthorne effect. I don't know if you guys have heard of the Hawthorne effect, but that basically says that when somebody knows they're being watched or they're being studied, they tend to do things like they're really supposed to. So it could be, you know, that they saw the clock there and they knew they were being timed, and they were much more aggressive at getting some of these patients through and up to, you know, where they needed to go. Picking up the phone and saying, hey, I need the bed now because I'm being watched and my bonus depends on it. I'll share it with you and I'll buy you a cup of coffee, might have influenced ultimately the effect. We don't know that to be true, but I think it's an assumption that certainly can be made. It is a single institutional review, and anytime you look at studies that only one institution is reporting their own data, you take it with a degree of skepticism. Their data looks pretty good, but it would be nice if 5 or 6 other institutions implemented something similar. They collected and cohorted their data and showed similar results. That would give a little bit more prowessness to the data, which is one of the reasons why we try to do multi-institutional research. It's a bigger data set, a bigger number of patients, bigger variabilities, but also with that comes the fact that now across multiple systems, you're showing this works. It can be replicated everywhere, but in my trauma bay. And then the third one I came up with, longevity of these results. You know, we came in, we did the study, we're no longer looking at this with any degree of, capacity. Does that mean now, if we were to go back to that same center today, that those numbers are the same? Or now that they're not collecting data, did they say, okay, they're not watching us anymore? We find that now the stopwatch is sitting behind one of the trauma carts and the batteries haven't been changed in 3 years. And again, don't know. But, you know, that's certainly one of the things that popped into my mind.
I was thinking, like, leading off of this, as you mentioned, the Hawthorne effect and the fact that now we have a metric or a very visible reminder may improve our expediency and care. I know recently they've been much more structured as to where, at least from the surgical team perspective, the trauma team stands. And there's the team leader, that's the one trauma resident, is the team leader position. As far as like possible future study, to develop an idea of what interval would be effective, like time interval, and having that be part of the team leader functionality, as far as hey, we're hitting a 10-minute mark, where are we as far as disposition, like what are we looking at, like, because I know they're not supposed to be like on the patient, but they're kind of looking at the big picture. And as part of managing that big picture, I know we love to try to put technology into every situation, not that a clock is such high technology, but I think ultimately care is delivered through people. And we all know, especially from a nursing perspective, when you don't have the people, care suffers, right? So involving a human component in the same capacity, right, as far as knowing our time and improving expediency, having that, whether it's 5 minutes, 10 minutes, or the first notification is at 15 minutes, right? So they're thinking through what they're working through in monitoring their team. but they can be the voice of prompt, right? Hey, they've been here for 5 minutes. Where are we at? 10 minutes, 15 minutes, or, you know, what I'm saying? Like,
Mhm.
not, I don't think it's too much of an added burden to that role, but I think maybe what the study shows us is that either whether it's the Hawthorne effect or that functionality improved the services, that can be rolled into a human component, which can deliver it more effectively.
No, spot on, Sam. I think you're spot on with that. And there are conceptual things out there in trauma resuscitation where they've actually labeled the scribe nurse and whoever the trauma lead is as kind of the pit bosses, and they work synergistically off of one another, making sure that benchmarks do occur. I mean, they are the flies on the wall, so they get that more 30,000 foot view of what's happening and making sure things get done, things don't fall through the cracks. So no, I agree with you 100%. I think that part of what we wanted to do in putting together this trauma manual and then developing how people are going to then or the orchestration, if you will, of how the team members interact is just the first, and I think what will be a long line of process improvement things that we work at. We'll eventually go into doing some sim stuff. We'll eventually then evolve that. And I think what you just said is a perfect logical step, somewhere 2 or 3 steps ahead of where we are now, if that makes sense.
Yeah. And I would like nursing to be that person, right? But in our setting and how we are staffed and how everything's structured, the reliance of having an actual scribe RN to be those eyes are not there. But I know we have that surgical eye. So
Yes.
at least, if we can't, maybe we can write up a nice grant proposal and say, hey, state, give us a nurse's salary for 2 years so we could run this study on our trauma program. And that could be a designated scribe, team, nurse leader, whatever position, and we can get some funding from that. But outside of that, it's certainly something that we could try to deploy.
I agree. I think Kat wants to say something.
Oh yeah, Steve. So I just want to just piggyback on what Sam had said. Maybe we should also consider, when we want to do this moving forward, multiple traumas, and how we handle that. How does time affect multiple traumas? If from the time of arrival, does the arrival of the trauma team affect the time of disposition for this patient? If they are in the OR, how many teams do we need to have? Would that affect the time? And also upgrades, the activation. If they came in the bedside first and activated to trauma, is it excluded in that study because they were not trauma alert or trauma code called in the beginning? And then lastly, what Sam said, staffing. Because like if you don't have a scribe and you have 1 nurse or 2 nurses, sometimes the task is we cannot complete it as fast as we should like it to be. So those are the few thoughts that I have regarding this study. But the study is great because it keeps us, eye on the goal, that we have to make sure that this patient is at this level, at this time, at this place at this time, and it should have a disposition at this time.
Agree with you guys. Very good points across the board. And that's something that you're right. The article really didn't. And that truly is a limitation. I mean, staffing is, and maybe at the time they did the study, it wasn't, but we certainly know today, if this study was done today with staffing issues that certainly not only that we find we're having, but that are absolutely universal across emergency departments and trauma bays from New York to California. What is the impact there? And we all know anecdotally that there is an impact, but these types of things, replicating them, if you will, when the situation is right, could certainly be food for thought for process improvement. And I'm recording this, so I'm gonna jot down some of these ideas and concepts, because one of the things, like I said, that I would love to see us do, collaboratively between emergency medicine and trauma is do some more collaborative research. That would just be the cat's meow for us aspiring for level 1 trauma status somewhere down the road, but for no other reason than just because it's cool to do and we should be doing it, right? So we'll head into the home stretch here. We got about 10 minutes left. So the conclusions that the authors kind of came up with was, first they look at the efficacy of time clocks in the trauma room. They found that it did result in reduced time in at least 2 of their segment populations in the department, which they viewed as being probably the 2 more important. And they found it was a simple, cost-effective method for implementation. And depending on what kind of clock they used, it certainly can be. I think they priced the clock out in this study at like about $400. And again, you can get really, really simple, go to Ace Hardware and get some pretty decent clocks that are highly visible that do work, or you can get really cool with the digital time pieces and all that stuff too. Maybe we get Rolex to sponsor a Rolex timepiece in our trauma bay. What do you think? But who knows? But I think their conclusions are relatively correct. I don't have any issues with them per se. I think that they did a good job of really proving that, having this clock, at least for their time period, comparing it with the data that they had prior to implementing this time clock, apparently, did do something good. And I threw these in because Sam had sent me, and thank you, Sam, had sent me some comments prior to, in case he couldn't hop on board. And I think, Sam, you have articulated them for the most part. I'll absolutely agree. I think anything we can do visually, and anytime we can have some kind of something there that is allowing us to remember that, we are on a time critical element. And the nurses, I think, tend to be more reticent to this sometimes than the surgeons do, and the residents do, and the medical students do, because more of a learning lab for them. I do know within our own set of trauma surgeons now, expediency and throughput is certainly a major determinant of what we're trying to continue to do. And we'll continue to look at that. But I think we've got a couple of potentially good ideas of things we can look to do at some point down the road with regards to throughput in our trauma bay, CPR bays. This can certainly go anywhere, if you will, but certainly during those more critical element type of patient situations. Well, bring you guys off of this, take us back to here. So, does anybody have any additional thoughts or comments? I think we've had some great comments that have come from everybody, but does anybody have any particular comments, things we missed, things that you saw in the article that I didn't particularly provide commentary on? Or did I hit everything straight like a big sledgehammer? Shayla?
I think you did.
Thank you.
Yes, I think you hit everything head on the nail as well. And I really appreciate the opportunity to participate with you guys tonight. I also, with the 2 comments that were made previously, piggybacking on those, if we did do a time study, if we could, with the human component in there and tie that into potentially with some grants that you could look at, we could tie it into some of the trauma service lines. If we could show where the ED length of stay critically reduced the hospital length of stay as well, then the bottom line for the hospital is going to increase. And then that would also be like a major, kudos to our team.
Absolutely. I mean, as we all know, we've got the foundation associated with the hospital. They've got individuals that are grant writers over there. This is something maybe that we can look to kind of feather out a little bit better, maybe get in cahoots with them, and maybe we can apply for some of the grants that are out there. An NIH grant could be made available, or grants from other sources, or even some philanthropic grants from some of the companies out there that like to fund these types of things. Or, hey, look, it's considered the dark side, but they're out there. You go to some of the companies that manufacture some of the products that also have research grants that are available. So who knows? But again, really, and for a couple of you that came in a little later, which again, thanks for joining us tonight. Really the inception behind the Trauma Nursing Journal Club really is that. It's just the ability to bring everyone together, look at something in the literature, be it a research article, be it a clinical article, digest it, talk about it, chat amongst friends about it, and really maybe take it, in some cases, take it to the next level, like this article might prove to do for us. but really kind of bring kind of more, I don't want to say academics to what we do, because that just sounds too pedantic. But take things that are just, we're taking each other from the bedside, but we're able to come together and digest stuff on a more clinical aspect without the pressure of timing and patient care and stuff like that going on. So like I said at the beginning, the Trauma Journal Club will be something we're going to try to do quarterly. I think that this one was very successful. We've got 6 people that joined, and I think that's phenomenal. And my charge to you guys moving forward is for the next journal club, you have to recruit 1 additional person to come. Going to make it mandatory. I know who you all are. I know where to find you. But we're also going to be doing a clinical topic called Topics in Trauma Nursing. The date on that, I got to lift my computer and look here, is going to be, it looks like, well, I may have to change it. I was originally accepted to be March 9th, but there's some stuff going on within our department that are going to kind of push some timelines back a little bit. But basically that's going to be just kind of getting someone who can sit down and do like a 30-minute talk on a topic of interest. And then some discussion on that topic, more obviously more clinically related, less like research, things like that. And we'll just kind of banter it back and forth. I don't intend it to necessarily be just trauma and emergency department. I want to open this up to peds and PICU and SICU and all of that as well. Topics sometimes will wax and wane of interest to people, and that's okay. That's just the nature of the beast. Trauma is multidisciplinary, so but my love is emergency, so it's always going to be a little toward the emergency side. So don't tell anybody in the SICU about that. But so does anybody have any questions or comments?
I think this is wonderful, Steve. I'd like to join.
Absolutely.
I never knew. I mean, this is my first time, and it's really very informative.
No, absolutely. Thank you. And like I said, I just want to kind of make it to be something that's a little bit different than what some of our clinicians, our nurses are getting, in standard education. So I hope that goal is achieved. Again, I appreciate everybody joining us tonight. Keep on the lookout. Billy is my marketer on this, so he'll continue to push this stuff out to you guys as we develop dates and get topics and stuff moving forward. If any of you have any thoughts, you see an article, you see there's a talk you want to give, maybe you have a case presentation, and I'll be honest with you, it doesn't always have to be trauma. We can make it emergency as well. Let us know. I love doing case presentations, and I think we learn a tremendous amount of stuff off of bizarre and unusual cases. And we have got an emergency department that's got to see some of the most bizarre shit in the world. So I'd love to see some stuff from the ED. But anyway, it's 3 minutes early. Let's get off here for the night. You guys go have a drink, dinner, whatever it takes. Keep an eye out, and I will see you on the next one. All right. Have a good night.